Spontaneous bacterial peritonitis is an infection of ascitic fluid in a patient with cirrhosis of liver in the absence of primary source of infection. Mean when the ascitic fluid get infected without any primary source, it is called as a spontaneous bacterial peritonitis. It is named as spontaneous bacterial peritonitis because it is a bacterial infection whose source is not known. So that is why it is called as a spontaneous. So a question arises that how the SBP develop. The SBP develop when the organisms such as E. coli, Klebsiella, Haemophilus, Enterococcus and other gram-negative bacteria reaches the peritoneum through the lymphatic spread or through the hematogenous. Hematogenous mean through blood and the lymphatic mean through lymph node. When these organisms through these two route reaches the peritoneum, it will infect the ascitic fluid and this infection is called as spontaneous bacterial peritonitis. The SBP develop in about 8% of cases and usually caused by a single organism called as a monomicrobial, and it is suspected in any patient of liver disease whose condition deteriorates clinically. So any patient whose clinically symptom get worsen, we should suspect spontaneous bacterial peritonitis. But what are the diagnostic clinical feature of spontaneous bacterial peritonitis? The clinical feature of spontaneous bacterial peritonitis include increasing ascites which is not responding to diuretics, along with sudden abdominal pain with rebound tenderness, with absent bowel sound and fever. Usually the abdominal signs are absent in about one-third of a patient. So fever and hepatic encephalopathy are the two diagnostic clues toward the spontaneous bacterial peritonitis. But the accurate diagnosis is made on the paracentesis. In paracentesis, we take the ascitic fluid and study the characteristic of ascitic fluid. In spontaneous bacterial peritonitis, there are four characteristic features in ascitic fluid. The first one is that the fluid will look cloudy, mean that it will be exudative in nature with high protein and low sugar. The second one is that the neutrophil count of fluid will be greater than 250 per millimeter cube. The third one is that on the culture and sensitivity, the ascitic fluid will grow a monoorganism. And the fourth one is that SAG, the serum ascitic albumin gradient, will be greater than 1.1. So all of these four features are the diagnostic for spontaneous bacterial peritonitis. So on a basis of clinical feature and paracentesis, we diagnose spontaneous bacterial peritonitis. Now come toward the treatment of spontaneous bacterial peritonitis. Usually we do not wait for the result of culture. When there is a diagnostic clue toward the spontaneous bacterial peritonitis, we directly use a broad spectrum antibiotic. The cefotaxime, the third generation cephalosporin, is a drug of choice. We give it in a dose of about 2 gram BD or TDS, and the alternate to this is a ceftriaxone plus amoxicillin. Along with that, we can use the intravenous albumin because it reduces the mortality. So these three therapies, cefotaxime, ceftriaxone with amoxicillin and albumin, are the treatment option for spontaneous bacterial peritonitis. Now come toward the prognosis and the prevention of SBP. The SBP show grave prognosis. The mortality rate in SBP is about 10 to 15% and it is an indication for referral to the liver transplant center. Along with that, the SBP is a recurrent disease, mean that it will reoccur. The recurrence rate of SBP is about 70% within 1 year. So usually we prevent the SBP in a patient with cirrhosis who develop ascites. How we prevent it? We prevent it by using antibiotic such as a norfloxacin or ciprofloxacin. Other than this, if there is a acute variceal bleed, so we should use a ceftriaxone 1 gram to prevent the spontaneous bacterial peritonitis. So it was all about the spontaneous bacterial peritonitis. But at last I will discuss one thing, that how we will differentiate the SBP from secondary infection. The SBP is differentiated from secondary bacterial infection through the following 5 criteria. The first one is that in secondary infection there will be high neutrophil count, means the neutrophil will be greater than 10,000. The second one is that the total protein will be very high, such as greater than 1 gram per dl. The third one is that the glucose will be low, such as less than 15 mg. The fourth one is that the ascitic LDH will be greater than serum LDH. And the fifth one is that on culture and sensitivity, there will be a development of multiple organisms. So these five things differentiate the SBP from the secondary bacterial infection. So it was all about the SBP. If there is still any question, you guys can ask and stay tuned for more update.